Welcome to session 5 of Rio 2022, day 2. This is a session that's going to be about presentations and then discussions. I'd like to welcome back Antonio Bruezo, Isabel Nault, and Julian Seitz. And first, I'm going to hand this over to Dr. Seitz, who's going to be presenting on AI for AFib ablation. Julian, over to you.
Yeah, thank you very much. So I'm very happy to be here, and thank you very much for the invitation. So the title of my presentation is AI for AF ablation. Here are my disclosures. So because each patient is unique, anatomical strategies after PVI over or under treat patients by definitions. As you can see on these slides, in different randomized clinical trial, PVI plus lines, PVI plus chemical ablation in the vein of Marshall, and PVI plus posterior wall isolation can be effective, of course, but if you look at the multiple procedures at 12, 18 months, the success rate after multiple procedures is between 50 and 60%. And only the Miguel Valderrabano randomized clinical trial demonstrated a superiority to classical ablation. So that is why the detection of AF drivers, in my opinion, is absolutely needed in persistent AF and or in case of PVI failure in order to perform a patient-tailored ablation and to adapt our strategies to each patient substrate. So what about visual electrogram-based detection of AF drivers? In the history of electrogram-based AF ablation, several targets have been described with promising but unfortunately only poorly reproducible outcomes. So first of all, in 2004 with Winademani's fractionation, and then Takayashi and colleagues, Sanjeev Narayan when they were in Bordeaux, Ganezan and colleagues, Amir Jadidis and Thomas Arends, and our group focusing not only on the fractionation but also on the local activation and talking more about dispersion than fractionation. All these strategies are very promising and effective in some single centers experience, but because AF signals are highly complex, only very trained experts are able to recognize AF drivers, electrograms visually. So here we can talk about an effective multi-parametric analysis, but that is very complex and subjective. So what about automated mapping of AF drivers? So we have today different tools that are available since many years that can try to analyze AF substrates. So we have CAFE maps, we have dominant frequency maps, we have also fibrosis maps on MRI. We also have low voltage maps we discussed previously, and all these tools are available. They are simple and objective. They provide a simple monoparametric analysis that is, of course, objective, but today that is non-normal or only poorly effective. We can discuss later. We have also different tools today that are available that perform a driver mapping using different technologies like Topera or ECGI. And these technologies can be efficient in some single centers experience, but also here the reproducibility is limited. And it's limited because drivers activation maps analysis is also complex and subjective. So because of AF complexity, an expert-like multi-parametric analysis is needed. So how to automatize a complex multi-parametric analysis? If you, for instance, here, a well-trained human brain is very powerful to perform a complex multi-parametric analysis, such as facial recognition or intracardiac electrogram analysis. But this task is very complex for classical algorithm. For instance, here, if I ask to a classical algorithm with only 1 or 2 variables to discriminate on these pictures, Chihuahua and muffins, you will see that it will be very, very difficult. But if you ask the same task to a machine learning algorithm, it will be much more powerful, and because the thresholds and a potentially high number of features are automatically extracted from data during the training. And here the boundaries will be much more accurate. So the question here is it possible to use artificial intelligence to guide AF ablation? So we have developed an algorithm with Volta Medical based on a database of intracardiac AF electrograms that we have collected and annotated based on the concept of dispersion that we published in the JACC in 2017. With this database, we have trained a multi-parametric AI-based software that provide in the EP lab a real-time electrogram analysis for the operator with a very simple interface with different colors. When the bipole of the catheter is blue, it's a cold area, so it's a bystander area. And when it's orange or red, it's a hot area. And so we tag these regions with tags, with clusters of dots on the 3D shell that will guide the ablation. So we have proposed an ablation workflow using this software that we call the tailored protocol. We believe that we have to adapt our strategy to each patient substrate. And so using this tailored protocol, the first step is to perform a biatrial AF mapping. Of course, we insist much more in the left atrium, but we also map quickly the right side. Then we ablate these regions. If there is a wide region, we can encircle this region. And then we complete the ablation set by connecting the regions each other if they are close and performing the PVI. So let me show you here a few examples of left atrium substrate using this software. So the substrate is schematized with the clusters of white dots. And you can see different examples showing how much each AFib and each patient is unique here, and how much, in my opinion, we should have a different ablation set in all these patients. Let me show you right now an example of a 50-year-old man with an 8-month persistent AF. So the mapping was performed using the Insight X from Abbott software, coupled with the Volta next generation software with a bidirectional communication between the Insight and Volta. And so you will see on the Volta interface here, the H grid is schematized, and the bipoles here on the upper frame of the interface turns into orange here, from blue to orange. So it's a hot region, it's a driver region. And so you can see on the 3D shell, the blue dots that are automatically displayed by the Insight X. So here again, on the anterior wall, on the septum, you can see a driver region with a lot of fractionated electrograms and dispersed electrograms. So we do a quick mapping in the right atrium very quickly, but you can see it's cold. There is nothing on the right side. So here I start my ablation on the anterior wall by this region. So we encircle this region completely. Okay, we are using 50 watts, so high power, short duration. Here we are ablating these regions, and we will use this ablation to perform what we call a tailored PVI, meaning that we include these driver regions in our PVI circle. So here I complete my PVI isolation on the right side. Here again, I ablate this region close to the left inferior PV. And you can see that by ablating here, AFib is progressively turning into a stable ATAC after 8 minutes of radio frequency. Okay, so at this step, we have a clear impact on the AFib substrate because we have organized AFib into ATAC. So at this step, we just do a classical activation map using the Insight X software. So we do a classical map using the HD grid and the Insight X. And you can see that this is a classical perimetral flutter very classical. So here we will just do an ablation, a linear ablation for this flutter. And we decided here to complete the ablation on the anterior wall and not performing a posterior lateral line, but here just a simple few applications in this low voltage area to connect the mitral valva to our circular ablation on the anterior wall. And we terminate the flutter directly into sinus rhythm. So at this step, it is not over completely. We have to complete our ablation set. So we have to complete the ablation of the blue cluster, of the blue dots cluster, and of course, by finalizing the PVI. And you can see it's a less than 2-hour procedures for 8 months persistent. And what is for me very interesting is that we have understood what we did. We have organized AFib into a macro reentry and then ablated this macro reentry. So we have performed this approach in a cohort of 85 patients with persistent and long-standing persistent AF, with 40% of structural heart disease. So, you know, it's not, it's very persistent patient with sick patients in 8 French sites and 17 operators using the 3 major mapping systems. And so the acute outcomes were very good, with 88% of AF termination, an average procedure time at 2.7 hours, and a total radiofrequency time at 43 minutes. At 1 year, we have 86% of freedom from AFib, 54% of freedom from any arrhythmia, meaning that after 1 procedure, it's not sufficient, but you can see that after 1.3 procedures, we increase the success rate to 73%. So importantly here, acute and long-term outcomes between primary and satellite centers were not different. So we achieved here with this protocol the reproducibility of electrogram-based ablation. So in conclusions, anatomical ablation approaches have a limited efficacy in persistent AF. It can work, of course, but by definition, these strategies over or undertreat patients. Because of AF complexity, the detection of AF drivers is only feasible by trained experts. AI allows for a multiparametric, complex, automated analysis that will certainly allow for more reproducible and better outcomes for AF patients. Volta and Cytix bidirectional communication allows for workflow simplification. And of course, all this data needs to be validated by randomized clinical trials. Thank you so much for your attention.
Well, thank you very much, Dr. Seitz, for that great presentation. It's amazing. I think you report 88% termination, and that's to sinus or flutter. Is that right?
Exactly. When we talk about termination, we talk about the Bordeaux definition of termination. So it means that we have its organization into ATAC or conversion into sinus rhythm. If we look at the conversion into sinus rhythm, we are around 65%.
Before we open it up to Antonio and Isabel for their thoughts on this approach, what do you believe is the mechanism of taking something that's fibrillatory and organizing it at a single lesion to flutter?
That's a very complex question. I don't know exactly, but I believe that atrial fibrillation is a mix between reentries, fast focal activity, and areas of heterogeneous conduction that are maybe secondary but can participate to the maintenance of AFib. And so what we observe in our approach is that by ablating these heterogeneous regions, by isolating these regions, we regularly organize AFib into stable attack. And so I believe that these attacks were present before, but were masked by this fibrillatory conduction. And very interestingly, we also observe in many examples, in many cases, that if you have 3 regions three regions that we have tagged as driver regions with our software. If you ablate one or two regions and you organize AFib into an ATAC, in many, many cases, the ATAC will be localized in the third region that was tagged in as an AFib driver region. You see what I mean? So this AFib driver region was stabilized into a reentry before any ablation in this region. So that's why I believe that there is a clear link between these fibrillatory heterogeneous regions and reentries. But I don't have any clear explanation, unfortunately. Yeah. So I don't have any clear explanation, of course, of the mechanism, but I think it's a mix between focal, rotors, complex reentries in 3 dimensions, and also macro reentries and micro reentries.
Thank you. Isabel, any thoughts and comments on this?
Well, could I ask a question, in fact, to Julian, because I'm pretty impressed with the results and the short duration of the short duration of RF that it takes to terminate the atrial fibrillation. And I was wondering, because we've been looking at those signals, we've been analyzing those signals, looking at the morphology of the signals, and you're talking to us about something different now that takes into account multiple parameters and look in analyzing it in a different way with artificial intelligence. Do you, with this analysis, bring into consideration the termination of the arrhythmia? In fact, my question is, in your model, do you only analyze the dispersion of in the signal morphology, or does the endpoint is also part of what you put into your model to make the software recognize that this is the right place, and maybe some things we haven't seen with our eye at this place was the right thing to ablate? Do you get what I want to ask with that question?
Yeah, that's a very good question. So yes, in the beginning, we observed that in some specific regions, as observed previously by many authors, that some specific signals can be associated by termination. Continuous cafe, for instance, when you record the whole cycle length in the region, this very low voltage signals, we talked before about low voltage, and that's exactly what we observe. Usually it's very low voltage signals, continuous cafe, etc., etc. And so we observed that, and we trained the software with this criteria. But as you said, when we observed in the critical areas that when we ablate a specific region, we terminate the arrhythmia, we extracted the signals map before, and we feed and we train the software with this software to give more weight on these specific electrograms, because we knew at this time that when we ablated these regions, these signals were maybe responsible for AF maintenance. So we gave some more weight to these signals to the other ones. But of course, we don't know when we terminate an arrhythmia. I think there is a cumulative effect. So we don't know. That's not because we terminate the arrhythmia on a region that all was done before was not important. See what I mean? So that's why we give a specific weight to this region, but we also use the other regions. I hope it's clear.
Antonio.
It is.
Okay, so I think we are doing something additional to only isolate pulmonary vein. Years ago, I spent hours and hours ablating out of the pulmonary vein, looking for cafes, looking for sites with higher frequency discharge or higher frequency electrograms, and sometimes I terminated AF. I never terminate AF, only isolating the veins. But at the end, when I follow the patients, I don't have best results when I ablate out of the pulmonary veins. Although I recognize we do different things. We can terminate AF in some cases acutely, but then during follow-up, outcomes are not different. So I'm not sure if this kind of procedure should be done or should not be done. Nowadays, I do an AF ablation for persistent AF in about 1 hour, and I have the same results as when I spend it maybe 3 to 4 hours burning and burning, and sometimes terminated, but outcomes are the same during follow-up.
Well, I think that the field is obviously starving for mechanism. It's starving for the PVI plus, the holy grail. And it's definitely amazing to be able to use the latest AI to be able to process signals differently. I mean, we've seen CardoFinder look for some sort of rotation. We've seen Acutis. We've seen wide temporal spatial dispersion, right, from France also come out. So everyone's looking for these drivers, but I think what's really impressive, again, it's nice to distinguish the value of termination, because I think that is relevant, but it's still hard to reconcile. I think you were saying, Julian, in your series that even though you had 88% termination, the outcomes were not significantly better than was that a historical cohort or any changes in recurrence. And that disconnect is also fascinating.
Oh, no, that's not what I said exactly. Maybe there's a misunderstanding. What we observed, and I didn't present this slide, but we had a clear difference in patients in whom AFib was terminated and others. So, of course, if we don't terminate AFib, we don't have 0% of success rate, of course. And PVI isolation, as you just said, Antonio, PVI isolation terminate AFib in approximately 10% of patients, depending on the studies, and there is no 10% of success rate at 1 year. So it doesn't. So that's, I agree that you don't need to terminate in every patient to have a good success. But on average, we do know that PV isolation is not sufficient for this kind of patients. 50% is not sufficient. 50, 60% is not sufficient after 2 procedures. So when you have a termination, it means that something's happening. So I think it's important for the understanding, but maybe in the future, we will understand also that in all these regions we are mapping, there are some primary regions and some secondary regions. And maybe sometimes it will not be necessary to ablate all these regions, and maybe not to terminate AFib in all these patients. So I agree that termination is important. It's mean that it's happening on the, something happening on the arrhythmia, that we are doing something efficient, but it's not necessarily to terminate to be effective in long term. And a
Another
good
way
ablation
of
set
looking at
with
this,
good lines is important.
another way of looking at this, because Julian was not offended by my VT analogy, but we know AFib is different from monomorphic scar VT, is that when you terminate VT, it doesn't guarantee you're going to get success and freedom from VT recurrence. And we've looked at that. If you terminate it, it's not like those patients do so much better. We like to see it. That's because any other VT can get you. All it takes is the 6 morphology to come out. So maybe there's multiple AFs, maybe there's multiple AF circuits and you get rid of one, but that's the real holy grail, is understanding, is this an ongoing flutter? My question, mechanistically, is the flutter ongoing the whole time and being overdriven by something else that's got a faster firing, and it's really just multifocal atrial tachycardia, and then it unmasks a stable flutter? Or was it not there the whole time, and then it just becomes one and it gets induced once you eliminate a focus by the last fire? And that's the question that I've been thinking about all the time, is what is that darn mechanism? And that's why it's fun to be able to pull these minds. And I think you were saying maybe it's just unmasking a flutter that was already there, but maybe just at a slower cycle length.
Yeah, I think that AF and ATAC are just 2 faces of the same coin. And I think that's also why it's very, to my opinion, very important to have a good ablation set. So that's why at the end of what we are doing, we recommend to spend some time completing the ablation sets and completing the lines, completing the PVI, and connecting regions each other, in order, of course, to avoid iatrogenic ATAC, if some are possible, but insisting on the ablation at the end, on completing the ablation sets. That's very important because, of course, as you said, you can have a good termination. You are very happy. But if you don't have performed a good transmurality and a good lockdown of the atria, with good lines and good lesions, I think it will not be sufficient.
Any correlation with your termination sites? We talked about the electrogram characteristics with low voltage regions. Have you done that analysis? It might be able to let us tie this together with Erase AF and some of the low voltage strategies.
Yeah, when I look at the Erase AF pictures, that's exactly what we are doing in terms of the way to ablate. So that's why I like this paper, because the way they ablate, they encircle the regions, they connect the regions, and I completely believe that that's a good direction to the way to ablate, to encircle and connect. But we didn't find an overlap between these dispersion regions and the low voltage regions. And as I said, there are some publications on the difference between voltage maps in sinus rhythm with different cycle lengths, different site of pacings. And so that is why I will be very cautious on voltage maps reliability to evaluate substrates. So in our opinion, and what we observe, there is no overlap between voltage and dispersion. There is no 100% overlap. There is an overlap, of course, and these low voltage fractionated and dispersed signals are very important, but there are lots of bystander low voltage regions, a lot of.
Dr. Seitz, thank you for that great presentation and interesting discussion. We're going to keep you around, obviously, to comment on Dr. Barroso's next presentation, non-invasive mapping, procedural planning, and ablation guidance of VT substrate. Dr. Barroso, over to you.
Okay, thank you. Okay, thank you, Rod, and thank you to all the organizers for inviting me. It is a pleasure to be here, and especially speaking about that, which is my main area of interest last year. So I'm going to speak about non-invasive mapping and procedure planning and ablation guidance depending on imaging. Okay, this is my disclosures. So to start, only to remember you that in the 2019 expert consensus statement on catheter ablation of ventricular arrhythmias, it was considered a class 2A recommendation to perform a CT scan and an MRI, both not only for planification of the access to try to ablate a given ventricular tachycardia or substrate VT ablation, but also to try to improve outcomes after ablation. This is due to the fact that more than 95% of clinical ventricular tachycardias originate in a left ventricular segment where we can find hyperenhancement. Okay, this is especially useful for patients with non-ischemic cardiomyopathy. Here you have an example, and you can see that the distribution of fibrotic tissue in non-ischemic cardiomyopathy is highly variable. And in the same patient, you can have fibrosis in the whole left ventricular thickness in some segments. In other segments, you can find only subendocardial hyperenhancement, subendocardial fibrotic tissue, and in others, you can find VT substrate where is fibrotic tissue only in the epicardium. So because of that, it is recommended to look for the morphology of the ventricular tachycardia, to analyze the possible segment of origin, and to go to look to this segment, suspected segment of origin, where the fibrotic tissue is located. In this case, you can see that the suspected origin is anterolateral basal because of the morphology of the VT, which suggests also an epicardial origin. And here in this patient, there is only fibrotic tissue on the epicardium, so you can choose to go. If what you want is to ablate the clinical VT, you can go only epicardially to ablate this VT in this given patient. Also, information of the MRI performed before the procedure can inform about the more probable success site for ablation in cases with septal VTs with septal fibrotic tissue. because the shortest distance to the scar is predictive of the ablation success from the left or from the right ventricle. So it is not only important for non-ischemic cardiomyopathy, but to know the distribution of fibrotic tissue along the left ventricular wall is also important for patients with ischemic cardiomyopathy and with a myocardial infarction. Here you can see in a cohort study we saw that VT recurrence-free survival was very good and was very similar in patients with only subendocardial scars and only endocardial ablation, in patients with transmural scar and endocardial plus epicardial substrate ablation. And what was clear here is that endocardial only ablation in a case of a transmural myocardial infarction is a very important risk factor for have recurrences in ischemic cardiomyopathy. MRI information can also give us the clue of some VTs that originate in papillary muscles because they are frequently associated to a scar located there. So, but we can also have information on the distribution of the border zone tissue into the scar, which is the tissue that is creating channels and sustaining VTs. If we obtain an MRI and we do a 3D reconstruction and we color codify the pixel signal intensity in the left ventricular wall, we can differentiate into the scar between core tissue and border zone tissue. And when we do this kind of 3D reconstruction and we compare the morphology of the scar and the distribution of the border zone tissue, the location and the extents with a voltage map, we realize that they are very, very similar, and this can help a lot to be focused in a given region in a small area many times, and this can facilitate ablation procedures. So the first important step is to get the images. What we do nowadays is to obtain always in every patient a CT scan and also an MRI. With the MRI, we will have the 3D distribution of the border zone corridors into the scar, and with the CT scan, we can have a left ventricular wall thickness map. So both are important. With CT scan, we will see some things, especially anatomy, and with MRI, we will have a better delineation of the border zone channels. So here you can see a video that is showing the distribution of the scar into the left ventricular wall. Here is clear that if you have to planify the procedure, you don't have to go epicardially because the scar don't reach the epicardium, so you will not have you will not find anything there. And you have seen also that the majority of channels or most of the channels are located endocardially. So for procedure planification is very important, and also the distribution of channels is giving you very important information. Here only to show you that MRI is more sensitive than wall thickness analyzed from CT scan to identify channels. These belong to the same patient. This patient had a septal scar. Here you can see that MRI identified two different channels, and when we look to the left ventricular wall thickness map, we were able to identify only one. This is because not always we have a transmural fibrotic tissue in ischemic and also in non-ischemic patients, and sometimes we have only subendocardial scars or mid-myocardial scars that do not produce any important wall thinning, and this is the reason why MRI is a little bit more sensitive than CT scan to identify channels into the ventricle. Here only to show you that in the image on the inferior left, this is you can see the channels identified by the MRI in a big scar zone, and here you have the activation map, and you can realize that really this patient, so the real histological substrate for sustaining this VT are the border zone corridors that we have identified into the MRI. In this particular case, the scar is turning around these both channels. Okay, this information belongs to a case control study we performed in patients with a post-myocardial infarction. Here you can see an image showing the way we identify the channels. Here you can see the center line of the border zone corridor and also the pixels that are forming part of this corridor that provide us the capacity to calculate the border zone channel mass. In red, you can see the core of the scar. And here you can see that we try to identify the determinants that we can analyze from an MRI that will be more related with the occurrence of a ventricular tachycardia after a myocardial infarction. After analyzing in multivariate analysis the left ventricular ejection fraction and any of the scar determinants, which are the total scar mass, the border zone mass, the core mass, and the border zone channel mass, the stronger predictor of events at every time after a myocardial infarction was the border zone channel mass, which is in fact the histological basis for the reentrant circuits. Here, an example of two different patients with an anterior infarction, with the same left ventricular ejection fraction, with the same quantity of grams of scar, same quantity of grams of core, same quantity of grams of border zone, and the only difference is that border zone in the case of the left is the transition between the core and the normal tissue, and on the right, in this patient, the difference with respect to the control patient is that border zone tissue is creating channels through the scar. So this is what is really responsible that a patient will have a VT during follow-up after a myocardial infarction. And this is the histological basis for VTs. Here you can see that the left ventricular ejection fraction less or more than 35% was not sensitive at all to identify those patients that will have VTs after a myocardial infarction, and that the presence of border zone channels, and especially patients with a critical border zone channel mass of more than 5.15, that was the best cutoff value, was directly related with the VT occurrence and left ventricular ejection fraction, as I told you, less than 35% was not related or not sensitive to identify patients that will have a VT after a myocardial infarction. So this was to show you that really this is the basis for having VTs. This is the histological basis or background for having a VT, and this can be used to help ablation. So here you can see on the left the way we do MRI-aided VT substrate ablation. We obtain first an electroanatomical map, a high-density map of the area of interest, and then we use also the information of the MRI, and we merge both information, creating a hybrid map. We compare the results of ablation with and without this information, and in a study of about 160 patients, we compared these two groups of patients with and without the help of the MRI to guide ablation, and we observed that we required fewer and shorter radiofrequency deliveries. We had fewer inducible VTs after ablation, and we had higher VT-free survival when we use information of the MRI introduced into the navigation system. So we were so confident with that we moved to perform MRI guided exclusively by the VTs, by the information of the MRI. So we compared these three groups of patients, and when only taking the electroanatomical map or anatomical map of the aorta and doing fusion with the information of the MRI and going directly to ablate the substrate that we identify into the MRI, we realized that this way of doing ablation permit us to perform shorter procedures with less need for fluoroscopy. Patients required shorter radiofrequency time to perform complete substrate ablation. We had lower inducible VTs after ablation, and we have with this way higher VT-free survival, as you can see in the Kaplan-Meier curves. So, but there are other imaging possibilities that I say go far beyond. So this is an example of a patient with an anterior myocardial infarction showing the extension of the scar and showing here, if you can look at them, the border zone channels. This patient had 4 border zone channels, 2 different views of the same patient, and you have also the distribution and the coronary arteries. And if you look carefully, you can see that you would be able to identify those branches of the coronary tree that irrigate each one of the channels. This could permit to do more focused ablations. In some cases, I show this image of a recently published paper by the group of Miguel Valderrábano on multi-vein, multi-balloon venous ethanol in cases refractory to left ventricular endocardial patient, endocardial ablation, that in whom it was impossible to go epicardially because of previous cardiac surgery, and the ablation was successful by doing this multi-vein, multi-balloon ablation. Maybe if we have this information before the procedure, we could simplify this kind of procedures, or whatever we would treat these patients. So this is an image of a patient of the last ablation we performed last week. And I would like to show this patient. On the left, you can see the VT activation map plus the FAT map obtained from a CT scan. And on the right, you can see the left ventricular wall thickness map and the FAT map, all together superimposed. So FAT is seen in black, and in red and blue, you can see the wall thickness map showing some channels in the scar area. Here in the activation map, you can see that the mitral annulus and the FAP is, so the movie is, I cannot show the movie. So anyway, you can see that the VT activation map shows that the VT is sustained by this VT isthmus, which is created by the insulated accumulation of lipulmatose metaplasia that can be seen from the CT scan and the mitral annulus, and maybe this can add some additional things to facilitate ablation in the future in patients in whom we only have the information of the CT scan, or even in every patient. So I think this, now we have the movie. Here you can see the VT circulating and using the isthmus, which is created by the fat deposition here and the mitral annulus. And this really can, I think, I'm convinced that can facilitate a lot ablations. Thank you for your attention. This is all.
Thank you so much, Antonio, for that great presentation. You've done so much wonderful work in advancing imaging characterization of the VT substrate. I'll leave it for comments with Dr. Seitz and Dr. Nault first. Isabel's unmuting.
Sorry. Very nice presentation. I was wondering, with this, the way you analyze the image, you process the image. Is it possible to do cross-sectional plans of the heart to see intramyocardial substrate? So that would be my first question. And my second question would be, have you correlated with epicardial scar with unipolar maps when you were doing the maps and the 3D mapping and the voltage mapping prior to using only the anatomical information?
So to decide the approach, we use always the image if we have it. But nowadays it's very strange. We don't have an MRI or a CT scan, at least. I could say that maybe 100% of the patients have information on the CT scan because it's a test that can be done in nearly every patient without artifacts, is very fast, and is available in nearly every single patient. And the MRI we have in about 50% of the patients, or maybe even more. For sure, you can estimate if you have intramyocardial or epicardial substrate with unipolar maps, but in the majority of patients, we have information from imaging obtained before the procedure. And the way we analyze, I think you were thinking about that. So the way we analyze fat is by modifying the intensity, the Hansfield units intensity in the segmented ventricle in between the endocardium and the epicardium, and is an anatomical, so an automatic display. So we select the level of Hansfield units, and automatically it is depicted. So it's very easy.
Dr. Seitz, comments and questions?
Oh, sorry.
Go ahead.
And have you used this this approach to this anatomy to perform stereotactic radiotherapy ablation for VT?
I have helped others, but I have not done in my institution. But this can, of course, be of help to be more focused when you treat this this way.
Dr. Seitz, questions and comments for Dr. Barroso?
Yeah. Yes. So so congratulations, Antonio. I'm very impressed by what you are doing. It's beautiful. I had just a few quick questions. The first one is, are you able to merge your delayed enhancement maps on the Carto easily? Do you have a software to do it, or is it feasible? And second question is, I'm very curious about your fat maps. That's very interesting. And have you tried to do this kind of fat maps for atrial arrhythmias also?
Yeah. Really, but the first question, you can introduce this kind of image in every Carto system. I think everyone should be prepared. And always someone has tried to do this kind of approach, have had no problems in using these kind of images into Carto. In fact, the image platform we use, which is called ADAS 3D, export images in a format able to be introduced not only in Carto, but also in Insight, for instance, and in Rhythmia system. So there is no problem for that. And the processing is very fast. You need only about 15 minutes to post-process the image you obtain. And we are doing also fat maps in the atrium. So because we sometimes are very concerned that, for instance, when we try to do an ablation line in the roof, we are not able, and we are sometimes burning. We don't know exactly why. And in the majority of cases, the reason to don't be transmural, to don't do a transmural line, is the left atrial wall thickness. We have left atrial wall thickness maps in a similar way that we have this kind of maps in the ventricle. When we see that we have a thickness of more than 3 millimeters, there is nearly impossible to do a complete ablation line in the roof. This is a bit strange because you know that you should be doing a deeper lesion. For instance, if you use 40 watts and you apply during 45 seconds, you should do a lesion deeper than 3 millimeters. But systematically, when we see that there is a left atrial wall thickness of more than 3 millimeters in the roof, we are not able to do a transmural lesion. When this happens, if we look at the fat maps, usually there is fat there. Maybe fat is acting as insulating for radiofrequency. This is helping in some of the cases, and we now are looking if these fat maps extend to some areas in which we have gaps related with recurrences in persistent AF ablation, especially in persistent, because in persistent we do very big circles and we go more to the body of the left atrium and not so much to thin zones in the pulmonary veins.
So much more to come from Antonio in the atrium as well. Antonio, we really want to thank you for your presentation, for the guy that coined the dechanneling technique. He's giving us so much more insight into the channels. So I want to thank Antonio, Isabel, and Julian for their excellent contributions to this session. There's still much more to come for day 2, so stay tuned. Thank you for the panel. So this is not the end of day 2 for Rio 2022. We still have a fantastic symposium coming up in a few minutes' time. However, I would like to briefly recap on today's proceedings where the focus has been mapping and ablation. We've had fantastic live cases on cryoablation with a transeptal system, concomitant AF ablation with left atrial appendage closure, and AF ablation with a novel flex tip contact force ablation catheter from London and Milano. We've had insightful presentations on LAA occlusion, AI for AF ablation, non-invasive mapping, procedural planning, and ablation for VT substrate. Most importantly, I'd like to thank all the faculty from today. This is truly a global faculty with great contributions from leading physicians and experts from both sides of the Atlantic. I'd like to also thank our industry partners for being able to support this, to continue it as a free-to-access model that is so central to Rio's philosophy. So special thanks to our headline partners, Boston Scientific and Medtronic, our partners Abbott and AtriCure, supporting partners Biosense Webster, EBR, and Volta Medical. And most importantly, we want to thank you, the viewers, for joining us in your thousands. Of course, we still have a third and final day left with Rio 2022 ahead of us tomorrow, where the focus will be therapy and technology. We're going to start at 1600 Central Europe time and 10 a.m. Eastern time. So from here in Phoenix, Arizona, I would like to thank you for joining us today, and be sure to stay with us for the following symposium. Good night, and we'll see you tomorrow.